Slide 1. This slide tape is the fifth in a series of presentations on acid-base physiology prepared by the American Physiological Society. 2. The subject of this program is disturbances of hydrogen ion regulation. Content expert, Dr. Richard Tannen. 3. The program begins with a review of prerequisite knowledge. Make sure you have completed the entry skills test provided in the study guide. During the program, question slides will appear at intervals. Stop the tape to answer the questions and to check your answers. After you finish, assess your understanding of the material by taking the post-test in the study guide. 4. The following topics will be discussed. 1. Classification of disturbances of acid-base metabolism. 2. The physiological adaptive response accompanying each disturbance. 3. A nomogram by which the type of acid-base disorder can be identified. 4. Appearance of a new acid-base abnormality in response to correction of the primary disturbance. 5. In the first 4 units of this series, you learned that hydrogen ion concentration is determined by the ratio of PCO2 to bicarbonate ion concentration as defined by the Henderson equation. The unique feature of this buffer system is that the 2 variables which determine hydrogen ion concentration are under independent physiological control. 6. The pressure of CO2 in the blood is a function of CO2 production from cellular metabolism and CO2 elimination by the lungs. PCO2 is regulated by the respiratory control system. 7. Bicarbonate concentration in the blood is a function of the relationship between hydrogen ion input from cellular metabolism and hydrogen ion output by the kidney. Bicarbonate ion concentration in body fluids is regulated by the renal system. 8. It is apparent from the Henderson equation that hydrogen ion concentration will be increased by either an increase in PCO2 or a decrease in bicarbonate ion concentration. Conversely, hydrogen ion concentration is diminished by either a decrease in PCO2 or increase in bicarbonate ion concentration. And if both PCO2 and bicarbonate ion concentration are altered in the same direction by comparable proportions, hydrogen ion concentration remains unaltered. 9. As your first objective, you should be able to 1. Specify whether hydrogen ion concentration, PCO2, and bicarbonate concentration are increased or decreased in a given metabolic or respiratory disturbance, and 2. List the cause of each disorder. 10. Acid-base disturbances fall into 3 major classifications. 1. Metabolic. 2. Respiratory. 3. Mixed. 11. The first major classification, metabolic acid-base disturbances, refers to primary abnormalities of hydrogen ion regulation, which result in alterations in bicarbonate stores. 12. Metabolic acidosis refers to a decrease in bicarbonate ion stores, resulting from either positive hydrogen ion balance due to excessive input of hydrogen ion or diminished output of hydrogen, or negative bicarbonate balance, resulting from loss of bicarbonate ion, as, for example, from the gastrointestinal tract. 13. Metabolic alkalosis refers to an increase in bicarbonate stores. It is logical to assume that metabolic alkalosis is the result of positive bicarbonate balance resulting from increased intake, or negative hydrogen ion balance resulting from renal or gastrointestinal losses. 14. However, the situation is slightly more complicated because the kidney excretes bicarbonate extremely efficiently. This results from the capability to filter larger quantities of bicarbonate ion than normal without increasing the rate of reabsorption. 15. Because bicarbonate ion excretion is so efficient, metabolic alkalosis does not usually result from an increase in bicarbonate ion intake alone, except in circumstances where bicarbonate ion intake is extremely massive or glomerular filtration rate is substantially diminished. 16. Rather, sustained metabolic alkalosis almost always requires the presence of an abnormality which causes increased bicarbonate reabsorption by the kidney. In this unit, we will not discuss in detail the pathophysiology of a persistently high rate of renal bicarbonate ion reabsorption which results in sustained metabolic alkalosis. We will mention two broad pathophysiological categories in which this occurs. 1. Metabolic alkalosis accompanying chloride depletion, and 2. Metabolic alkalosis associated with increased secretion of mineralocorticoid. Details of these abnormalities should be studied in other sources. 17. The second major classification, respiratory acid-base disturbances, refers to primary abnormalities of CO2 regulation which produce changes in arterial PCO2. 18. Respiratory acidosis results from an increase in arterial PCO2. Theoretically, this could result from increased production of CO2 or from decreased alveolar ventilation. 19. However, the lungs are such efficient excretory organs that the only clinically apparent abnormalities of PCO2 regulation result from changes in alveolar ventilation. Hence, respiratory acidosis is synonymous with decreased alveolar ventilation, due, for example, to a disturbance of the respiratory center or to a primary pulmonary abnormality. 20. Respiratory alkalosis refers to a decrease in arterial PCO2 and results from increased alveolar ventilation. 21. In any acid-base disturbance, an increase in blood hydrogen ion concentration is called acidemia, and a decrease in hydrogen ion concentration is called alkalemia. When only one acid-base disturbance exists, acidosis is accompanied by acidemia and alkalosis by alkalemia. For instance, respiratory acidosis in which plasma PCO2 increases, or metabolic acidosis in which plasma bicarbonate decreases, results in acidemia and is accompanied by an increase in hydrogen ion concentration in the blood. The reverse is found in alkalosis. 22. In the third major classification, mixed acid-base disturbances, abnormalities in both bicarbonate and PCO2 regulation occur simultaneously. When such mixed disturbances are present, hydrogen ion concentration will be determined by the predominant abnormality. 23. Remember to stop the tape to answer questions and to check your answers. 24. 25. 26. 27. Your second objective is to 1. Indicate the adaptive response or responses accompanying each primary acid-base disorder, and 2. Indicate the time taken for each. 28. Chemical buffering is the body's first line of defense in the protection of normal hydrogen ion concentration. This defense mechanism is implicit in the isohydric principle. It occurs immediately and minimizes the effect of primary changes in either bicarbonate concentration or PCO2 on hydrogen ion concentration. 29. For example, during acute respiratory acidosis, CO2 retention is reflected by an increase in carbonic acid. This acid load is buffered by non-bicarbonate buffers, minimizing the change in free hydrogen ion concentration and generating bicarbonate ion. Plasma bicarbonate is thereby increased. 30. In respiratory acidosis in the presence of non-bicarbonate buffers, the percentage increase of PCO2 is greater than the percentage increase in bicarbonate ion concentration, so that the net result is an increase in hydrogen ion concentration. For instance, given normal conditions of acid-base balance, a 50% increase in PCO2 results in a 12.5% increase in bicarbonate concentration and yields a 37.5% increase in hydrogen ion concentration. 31. In the absence of non-bicarbonate buffers, plasma bicarbonate ion concentration remains unchanged in the face of an increase in PCO2, and the defense of hydrogen ion concentration is less effective. For instance, the same 50% increase in PCO2 with no change in bicarbonate ion concentration would lead to a 50% rather than 37.5% increase in hydrogen ion concentration. 32. In addition to buffering, physiological adaptive responses modify the impact of changes in PCO2 or bicarbonate concentration on hydrogen ion concentration. These physiological adaptive responses involve the respiratory system and the renal system. 33. When the primary abnormality is metabolic, that is, a change in bicarbonate ion concentration, the adaptive response is respiratory. Through changes in ventilation, respiratory adaptation results in a change in PCO2, and hence changes in hydrogen ion concentration. Since the respiratory control system responds rapidly to changes in hydrogen ion concentration, respiratory adaptation to metabolic disorders occurs quickly and achieves a new steady state within minutes to hours. 34. Specifically, in metabolic acidosis, a primary decrease in plasma bicarbonate ion concentration with accompanying increase in hydrogen ion concentration results in an adaptive increase in alveolar ventilation. This produces a decrease in PCO2, which returns hydrogen ion concentration toward normal. The final overall effect is an increase in hydrogen ion concentration, but the magnitude has been blunted. 35. Conversely, an increase in plasma bicarbonate concentration and accompanying decrease in hydrogen ion concentration leads to an adaptive decrease in alveolar ventilation. This produces an increase in PCO2, which returns hydrogen ion concentration toward normal. It should be pointed out that since decreased alveolar ventilation simultaneously decreases the pressure of oxygen in the blood, respiratory compensation to metabolic alkalosis is constrained by the accompanying hypoxia, and therefore is more limited than the change which accompanies metabolic acidosis. 36. When metabolic acidosis results from a sustained increase in hydrogen ion input, as in constant ingestion of sulfuric acid precursors, the adaptive response is renal as well as respiratory. The kidneys adapt by progressively increasing the rate of hydrogen ion excretion, so that by 3 to 5 days, the excretion approximates the increased rate of hydrogen ion input. The result is maintenance of a stable, although diminished, plasma bicarbonate ion concentration in the face of increased hydrogen ion input. 37. The effectiveness of the renal adaptive response determines the plasma bicarbonate ion concentration associated with a given acid intake. Thus, with a chronic increase in acid input, the final hydrogen ion concentration is a composite of the renal adaptation, which determines the bicarbonate ion concentration, and the respiratory adaptation, which determines the PCO2. 38. When the primary abnormality is respiratory, that is, a change in PCO2, the adaptive response is renal. Renal adaptation results in a change in plasma bicarbonate ion concentration. This adaptation generally requires from 2 to 4 days to achieve a steady state. 39. An increase in PCO2, respiratory acidosis, and attendant increase in hydrogen ion concentration results in increased renal hydrogen ion excretion and in a corresponding increase in bicarbonate ion generation and plasma bicarbonate ion concentration. 40. The decrease in PCO2 during respiratory alkalosis results in a decreased hydrogen ion excretion and a corresponding decrease in plasma bicarbonate concentration. 41. 42. 43. 44. 45. As your third objective, you should be able to, given the quantitative dimensions of the adaptive responses, utilize a nomogram to identify mixed acid-base disorders. 46. It has been demonstrated empirically that within a normal population there is a predictable quantitative as well as qualitative adaptive response for any degree of primary disturbance in plasma bicarbonate ion concentration. This is the PCO2 bicarbonate ion relationship, which depicts the predictable respiratory response to metabolic disturbances. 47. In view of the Henderson equation, the PCO2 bicarbonate ion relationship can be expressed in terms of hydrogen ion rather than PCO2. It should be noted that the hydrogen ion response to changes in bicarbonate ion is a continuum. That is, the more severe the change in plasma bicarbonate concentration, the greater the perturbation in hydrogen ion. 48. In addition to the PCO2 bicarbonate and hydrogen ion bicarbonate relationships in the respiratory response to metabolic disturbances, this adaptive response could also be depicted on a hydrogen ion PCO2 diagram. The purpose for giving the relationship in this fashion will be its ultimate combination on one nomogram with primary disorders of the respiratory system. Only one curve is required to depict the relationship in metabolic disturbances, since the adaptive response by the respiratory system is acute. 49. The hydrogen ion PCO2 relationship can be of value clinically when expressed as a nomogram by bracketing the response with confidence bands which encompass 95% of the responses expected by a normal population. As a corollary, if a value falls outside these confidence bands, as for example points 1 or 2, there is a 95% chance that a pure metabolic acid-base disorder does not exist. 50. In contrast to metabolic acid-base disturbances, the quantitative responses to respiratory acid-base disturbances must be segregated into acute disturbances, in which the short-term response is buffering, and chronic disturbances, in which the long-term response depends on renal compensation. 51. As with metabolic abnormalities, it has been found empirically that a hydrogen ion PCO2 nomogram can be depicted describing the normal response to acute respiratory acid-base disorders. Recall that plasma bicarbonate ion concentration is increased when PCO2 is elevated and decreased when PCO2 is diminished as a result of the PCO2 interaction with non-bicarbonate buffers. 52. If an abnormality in PCO2 is sustained for more than 24 hours, renal adaptation becomes apparent. Plasma bicarbonate ion concentration generally achieves a new steady state in 2 to 4 days. 53. Note that defense of hydrogen ion concentration is more effective in chronic respiratory disturbances than in the acute disturbances at any given PCO2. This chronic response is more effective because renal adaptation results in larger changes in plasma bicarbonate ion concentration than the changes due to chemical buffering. Renal compensation returns hydrogen ion concentration toward, but never completely to, normal levels. 54. It should be apparent that it is possible to construct a master diagram which includes the hydrogen ion PCO2 response to all primary acid-base disturbances. This approach provides a useful tool for analyzing acid-base abnormalities in the clinical situation. 55. If a patient manifests acid-base parameters, as depicted by points 1 and 2, which do not fall within any of the confidence bands, it can be assumed with a 95% degree of confidence that a single primary acid-base disorder is not present. However, it must be emphasized that values such as point 3, which fall within a confidence band, are consistent with, but do not guarantee the presence of, that particular disorder, in this case, metabolic acidosis. 56. Given the following data, locate and number each point on the diagram, and choose the acid-base disorder that corresponds to each point. 57. 58. As your last objective, you should recognize that the rapid correction of a primary acid-base disturbance may result in the transient development of a different acid-base abnormality. 59. Respiratory acid-base disturbances are rapidly corrected either by reversal of the underlying abnormality or by therapeutic interventions that rectify alveolar ventilation, such as the use of a mechanical respirator. Reversal of the disturbance may take place within minutes to hours. Reversal of the adaptive renal response to respiratory abnormalities depends on excretion of either the excess bicarbonate ion or hydrogen ion, and generally requires several days to accomplish. 60. It should be emphasized that this rapid correction of the primary abnormality may result in temporary development of a new abnormality, related to the different time course required for correction of the adaptive response. 61. A good example of this phenomenon is demonstrated with rapid correction of chronic respiratory alkalosis. Note that when PCO2 is returned to normal, additional time is required for the kidney to restore plasma bicarbonate ion concentration to normal. Hence, there is a transient phase with a low plasma bicarbonate ion concentration and normal PCO2, that is, metabolic acidosis. 62. Similarly, rapid correction of a chronic respiratory acidosis may result in a transient metabolic alkalosis. 63. Appreciate, however, that when acute respiratory disorders are corrected, no physiological adaptive response has taken place, and therefore a secondary abnormality cannot develop. Correction only requires back titration of the non-bicarbonate buffers, a chemical phenomenon which takes place promptly. 64. Metabolic acid-base disturbances can be corrected rapidly either by reversal of the underlying abnormality or by the therapeutic administration of hydrogen ion or bicarbonate ion. However, the adaptive changes in ventilation may take hours to reverse. 65. As would be anticipated, rapid correction of primary metabolic acid-base disturbances can result in transitory respiratory disturbances. 66. 67. 68. The response of the PCO2 bicarbonate system to acid-base disturbances has been reviewed. It has been pointed out that all primary disorders are accompanied by physiological adaptive responses which tend to return hydrogen ion concentration toward normal. 69. These responses have predictable quantitative as well as qualitative dimensions, occur within a given time framework, and may result temporarily in different abnormalities during correction. Knowledge of all these factors is important for the clinician in diagnosis and management of the patient with disorders of the acid-base system. 70. This concludes the discussion of disturbances of hydrogen ion regulation. Refer to your study guide for the post-test and references for additional reading.